All right, this next group of drugs are a little complicated in the fact that they have so many clinical indications. This is kind of the introduction to immunosuppression. So officially, these are drugs that alter metabolism and not organismal metabolism. We're talking about cell metabolism. So think DNA, RNA, protein production, that kind of thing. The first group of drugs that we're going to talk about are aminosalicylates. And so the prototype here is sulfasalazine. Other aminosalicylates are all listed here. And from the GI perspective, the only thing that's really different about them, other than the fact in terms of like clinical outcomes, is their distribution through different portions of the intestine, which is shown here. And so for a lot of this is really kind of above where we need to be, but I just want to kind of give you a glimpse as to how these drugs kind of fit into these categories. So mechanistically, we don't really know how they work completely, but we know that when you give any of these drugs to GI type of tissues that are inflamed, the result is immunosuppression. Okay, and from a structural standpoint, again, looking at salicylates, they're very similar to aspirin. So you could think maybe of the COX prostaglandin leukotriene pathway as being somehow inhibited through some of these drugs. So where do we see a lot of aminosalicylates? Ulcerative colitis, Crohn's disease, and a few others, I'm sure, but I just narrowed it down to two. Other drugs include azathioprine. So azathioprine, also known as 6-MP, is really a purine antimetabolite. So it looks like a purine molecule, but when it gets incorporated, it becomes an anti-metabolite. That's because it gets converted to this compound called 6-mercaptopurine. And then from there's multiple metabolic conversions. That's a little bit probably too much more chemistry than we need. But of course, what we're looking at is how these purines get incorporated into the DNA molecule. And they can because they are nucleotides. And so what happens is that they become incorporated into these nucleotides, and the structural integrity of the molecule is compromised severely. And what happens is that the cell basically arrests or stops cell proliferation because the RNA DNA synthetic pathway is severely restricted. In terms of the kinetics, these are drugs that are orally administered. They're basically along the realm of chemotherapy / immunosuppression. You can see them used clinically as an adjunct or assistance to organ transplant, rheumatoid arthritis, Crohn's disease, celiac disease, and a whole host of others. We'll talk about these drugs in several different cases and scenarios. And of course, they're very similar to chemotherapy. One could argue they are chemotherapy. You can see bone marrow suppression, and you can see a production of leukopenia as well as thrombocytopenia in terms of toxicities, as well as just even side effects. There are well-known drug interactions, including xanthine oxidase inhibitors as well as ACE inhibitors, which we've talked about. Excuse me. Other immunosuppressive agents include ECMPS, or enteric-coated mycophenolate sodium. And basically, all this drug does is it inhibits the de novo synthesis of GMP. This comes from a fungal metabolite called mycophenolic acid. Okay, and again, this is a selective, non-competitive, reversible inhibitor of a specific enzyme called inosine monophosphate dehydrogenase. Okay. And again, that's probably even more chemistry than what you need to know. What are we looking at? Well, what cells rapidly turn over the most? Lymphocytes. And so a lot of these drugs have profound lymphocyte proliferation and lymphocyte growth inhibition. They also, through way of inhibiting lymphocyte activity, they have a reduction in antibody formation. They also inhibit the ability of lymphocytes to move from lymphatic tissue to inflamed tissue. And they also inhibit their ability just to move from point A to point B through the lymphatic vasculature. Excuse me. And there are some pharmacokinetic considerations to consider in terms of half-lives of certain metabolites, excreted into the urine, and then what that does on renal physiology. And so, we can use these in some of the GI inflammatory diseases like Crohn's or celiac or ulcerative colitis and so forth. But you see a lot of ECMPS used for the prophylactic treatment of patients that are going to undergo transplants, so solid organ transplants, kidney, liver, lungs, etc. You can see some nasty toxicities, including GI and hematologic toxicities, ironically enough, diarrhea and vomiting, as well as co-infection with CMV, tons of drug interactions, and then also you can see some absorption changes depending on the pH of the intestines. So this drug has a lot of uses clinically outside of some of the GI type of conditions, but it has been shown to be clinically efficacious in some of the diseases that are on our differential for the Donner case. The last group of drugs that we're going to talk about that are deemed the immunosuppressive type agents include methotrexate. And this is more of an introduction to methotrexate. Methotrexate we can talk about for at least an hour. But basically what this drug does is it interferes with folate metabolism, specifically the enzyme dihydrofolate reductase. And that's going to primarily affect thymidine and purine synthesis. We use methotrexate for a lot of conditions that are inflammatory mediated. A few of them are listed here: chronic inflammatory diseases, Crohn's, of course, rheumatoid arthritis, and cancer. Methotrexate has a wide administration portfolio. It can be orally, subcutaneously, or intramuscularly administered. So that's it for the immunosuppressive agents. This is an introduction. We have probably another 2 hours or so of lecture material on immunosuppressive agents, kind of spread across the curriculum, so it's not that much of a burden on you. This was kind of the first time you're going to see these drugs, so we took it a little bit easy on you. But hopefully you can kind of connect the dots and come up with a rationalization as to why you would use some of these drugs for this particular patient, or some of the patient vignettes that are going to be discussed in the workshop type settings. Okay, thank you.